Hello my dear friends. So as a part of the continuation of the ECG series, in this session let me take up the discussion of the supraventricular tachycardias, that is Av Nrt and as well as Av Rt. So Av Nrt, it stands for Av Nodal Reentrant Tachycardia, whereas Av Rt, it stands for Atrioventricular Re-entrant Tachycardia. So this is what is the Av Nrt and as well as the Av Rt. Now if you take the terminology, that is supraventricular tachycardia, both of them, they are the supraventricular tachycardias. So please remember, the term supraventricular tachycardia refers to any tachyarrhythmias arising from above the level of the bundle of His, right? So this is the bundle of His. So any tachyarrhythmias which are arising above the bundle of His and encompasses regular atrial, irregular atrial and regular atrioventricular tachycardias, right? So any arrhythmias or any tachycardias which are originating, where the impulse is originating above the bundle of His, we call it as supraventricular tachycardias. Either they can be regular atrial rhythm, irregular atrial rhythm like atrial fibrillation or atrial flutter, or there can be regular atrioventricular tachycardias. Now, after having discussed about what exactly you mean by the word SVT, now let me tell you what exactly you mean by these two words, that is Av Nrt and as well as the Av Rt. So Av Rt, what is that we have discussed? That is Atrioventricular Re-entrant Tachycardia. In Atrioventricular Re-entrant Tachycardia, you have the accessory pathway between the atria and as well as the ventricle. So the re-entry will be in between the atria, ventricle and again back to the atria. Whereas if you take in case of the atrioventricular tachycardia itself, the re-entry can be from ventricle back to the atria. Accordingly, we call it as antidromic AVRT and as well as orthodromic AVRT, which I will discuss in detail in the further part of the session. But remember, in case of AVRT, the re-entry is in between the atria and as well as the ventricle. Either it might be antidromic or orthodromic. What is that? I will discuss that in detail. Now, coming to your Av Nrt. In case of Av Nrt, the re-entry will be around the Av node. Now, in case of the Av Nrt, you have the fast pathway and as well as the slow pathway. So there will be re-entry around this particular Av node itself. That is what is called as Av Nrt. Now, what exactly is the mechanism for the re-entry? I will be discussing that in detail in the further part of the session. So in this slide, I just wanted to tell you like what is the difference between AVRT and as well as the Av Nrt. Now, after having discussed about the basic differences between AVRT and as well as Av Nrt, let me take up the detailed discussion related to the PSVT, Paroxysmal Supraventricular Tachycardia. Now, what do you mean by this word, the paroxysmal supraventricular tachycardia? Paroxysmal supraventricular tachycardia, remember that word paroxysmal, it tells you that it is the supraventricular tachycardia which is abrupt in onset. Right, which is abrupt in onset and as well as the offset. That is characteristically seen with re-entrant tachycardias involving the Av node such as Av Nrt or the Av Rt. That is what is paroxysmal. The word paroxysmal means the onset, it should be abrupt in onset. Now, let me take up the detailed discussion of Av Nrt first and then I will take up the discussion of Av Rt. If you take this Av Nrt, we have the various types of Av Nrt: slow fast Av Nrt, fast slow Av Nrt, slow Av Nrt. Now you see this multiple choice question. Which is the most common subtype of Av Nrt? slow fast AV Nrt, fast slow AV Nrt, slow slow AV Nrt, fast fast AV Nrt. What is all this? I will discuss in detail now. But you should know that the answer is slow fast AV Nrt. That is the most common type of AV Nrt. Now by now you might have got a doubt, what is this slow fast, what is this fast slow, what is this slow slow, all that I will discuss now. So I said you that you have these three types of the AV Nrt. Out of all these, which is the most common type? Slow fast AV Nrt, it constitutes nearly around 80 to 90%. Right? Slow fast AV Nrt, it constitutes nearly around 80 to 90%. So we have different subtypes. These three different subtypes have been classified based on the RP interval. Now what is this RP interval? It should be actually PR interval, right? Then what is this RP interval? RP interval, which is the time between the anterograde ventricular activation, that is R wave, and retrograde atrial activation, that is P wave. That is what is called as the RP interval. That means in case of RP interval, remember, it is the ventricle which will contract first. Right? It is the ventricle which will contract first. Then followed by that, the atria, it will contract later in a retrograde fashion. Right? Atria which will contract in a retrograde fashion. That is what is called as the anterograde ventricular contraction and retrograde the atrial activation. And that will give rise to what is called RP interval. So based on this particular RP interval, we classify the AV Nrt into slow fast, fast slow and slow slow AV Nrt. Now, if you take the AV RT, see what is this? We have discussed AV Nrt. But if you take AV RT, that is Atrioventricular Re-entry Tachycardia, what did I tell you? The accessory pathway is present between the atria and ventricle, and the re-entry is between the atria and as well as the ventricle. And what is the incidence of the AVRT in healthy population? That is nearly around 0.1 to 3 per 1000 healthy subjects. And this AVRT, that is your accessory pathway, which is present between atria and as well as the ventricle, that is responsible for your atrioventricular reentrant tachycardia. And this accessory pathway can be on the left side, that is in between the left atrium and as well as the left ventricle, or this particular accessory pathway, this can be on the right side, that is in between the right atrium and as well as the right ventricle. So if the accessory pathway is on the right side, you will see that in patients with the Epstein's anomaly, right? You will see that in patients with the Epstein's anomaly. What is Epstein's anomaly? Epstein's anomaly is the clinical scenario where there will be distal displacement of your tricuspid valve, where there will be atrialization of the right ventricle, which is a congenital abnormality. That is called Epstein's anomaly. And in Epstein's anomaly, right-sided accessory pathways are very common. So that is about your AVRT. Then in the introduction, I was telling you that AVRT, where you have the re-entry between atria and ventricle, it can be in antigrade fashion or it can be in a retrograde fashion. And accordingly, what did I tell you? We have two types: orthodromic AVRT, antidromic AVRT. Now what is that? I will discuss in detail at this moment of time. So you see these images. First of all, you need to know what is pre-excitation. Pre-excitation, you will have that in patients with the WPW syndrome, that is Wolff-Parkinson's White syndrome, where you have the presence of the accessory pathway between the atria and as well as the ventricle. Why do you use that word pre-excitation? Why? Because you take in a normal individual, the atrial impulses reach the ventricle through the AV node. So from the SA node, whatever the impulses are generated will pass through your internodal fibers and they will reach the AV node. And from the AV node, the impulses have to go to the ventricle. That is what will happen in a normal individual. But in case of the pre-excitation syndrome, what will happen? The impulses from the SA node will enter into the ventricle through the accessory pathway, not through the AV node. That means the ventricle is getting excited before the normal time, and that is the reason why we use this word pre-excitation. So in case of the pre-excitation, there like WPW syndrome, Wolff-Parkinson's-White syndrome, that is also a type of the AVRT, Atrioventricular Re-entry Tachycardia. And what is the name of the accessory pathway in case of WPW syndrome? That is your bundle of Kent. And what will be the ECG features in case of your WPW syndrome, which is a pre-excitation syndrome? First and foremost, you have a short PR interval. Now, why is that you have short PR interval? Because the ventricle is exciting before the normal time. That is the reason why you have the short PR interval. And the second important thing is the QRS complex. In the QRS complex, you have the presence of what is called as the delta wave. Right, you have the presence of what is called delta wave, and even if you see the QRS complexes, you have wide QRS complex. That is what you will see in the pre-excitation syndrome. Then, followed by that, we have the two other types, orthodromic AVRT and as well as the antidromic AVRT. You take orthodromic AVRT. In case of orthodromic AVRT, the wavefront travels via AV node to the His bundle and ventricles, but travels retrogradely via the accessory pathway. So, the impulse from the AV node to the bundle of His to the ventricle, and from the ventricle it will go back to the atria. So, this is what is called as the orthodromic AVRT. Whereas you have another form, that is the antidromic AVRT. Here the wavefront travels via the accessory pathway to the ventricle, right? So via the accessory pathway, the impulse will reach the ventricle, and from the ventricle it will reach the AV node and then back to the atria. So in orthodromic AVRT, please remember the conduction is from atria to the ventricle and again to the atria. Whereas in antidromic AVRT, the impulse will reach the ventricle via accessory pathway. From the accessory pathway, it will go to the ventricle, and from there to the atria, and again to the accessory pathway. So this is the pathway in the antidromic AVRT. So orthodromic, that is from atria to the ventricle and then again back to the atria retrogradely. Whereas antidromic, from the accessory pathway to the ventricle, then again to the atria and again via the accessory pathway. So that is very simple to understand difference between orthodromic and as well as the antidromic AVRT. Now what will be the ECG features? Now you take in case of the orthodromic AVRT. In orthodromic AVRT, the ventricle is receiving the impulse from the atria through the AV node. So you have the normal QRS complex, right? You have the normal QRS complex, and from the ventricle again the impulse is going back to the atria. So the atria is receiving the impulse in retrograde manner. So the P wave will not be upright, the P wave will be inverted, and that too the P wave will appear after the QRS complex. Why? Because after the ventricle getting activated, the atria is getting activated in a retrograde manner. So that is the reason why you have the QRS complex and then P wave and then T wave. Okay, see, if it was like atria ventricle, then you will have P wave and then QRS complex. But here what is happening? Atria, ventricle, and again atria back again. So you will have the QRS complex, then the P wave of your atrial contraction, and then again QRS complex. So after A wave, again after your atrial contraction P wave, you will have T wave, right? T wave, and then QRS complex, then P wave, then T wave. So this will be the ECG features in case of orthodromic AVRT. See, please don't get confused. Very simple. the ventricle is getting activated first and then atria is getting activated in a retrograde manner. So QRS, P wave in retrograde, that is inverted, and then T wave which is upright. Then antidromic AVRT. In antidromic AVRT, the ventricle is getting contracted through the accessory pathway. So that is the reason why the QRS complex will be wide, and as well as you have the presence of the delta wave. And the P wave, it is rarely seen, and if P wave is visible, it is retrograde and occurs just before the QRS complex. Okay, so these are the ECG changes in pre-excitation, orthodromic AVRT, and as well as the antidromic AVRT. But let me tell you in detail about the AVRT, the ECG changes. In case of orthodromic, what did I tell you? Definitely reentrant tachycardia means the rate will be on the higher side, 200 to 300. And what will happen to your P wave? The P wave may be buried in the QRS complex, or it may appear retrogradely. And the QRS complex is normal, that is less than 120 milliseconds. And the T wave inversion is common. So in case of the orthodromic AVRT, you have the QRS complex, then retrograde P wave, and then the T wave, right? The T wave may be upright or it may be inverted. So that is about your orthodromic AVRT. Antidromic, already I have said you will have wide QRS complex, delta wave will be there, P wave may or may not be present. So that is about the story of your AVRT, Atrioventricular Re-entry Tachycardia. Now let me discuss in detail about the Av Nrt, that is Av Nodal Reentrant Tachycardia. So you should know what are the drugs which will cause Av Nrt. Drugs causing Av Nrt are all except salbutamol, amphetamines, alcohol, and then sotalol. The answer to this particular question is the sotalol. Sotalol, it is a beta blocker, and not only beta blocker, it is a class 3 antiarrhythmic drug. So Av Nrt, what are the etiologies? Number 1, drugs. What are those drugs? That is beta 2 agonist, that is salbutamol, sympathomimetic amines, that is amphetamines, and alcohol, can all predispose to the development of the Av Nrt. And not only that, this particular Av Nrt can also be seen on exertion, right? And it can also occur on excessive consumption of the coffee and as well as the tea, right? And this Av Nrt, please remember, it is more common in women rather than men, right? It is more common in women than men. 75% of cases they occur in the women. So that is about the Av Nrt etiologies. Now what will be the clinical features of the Av Nrt? The clinical features of the Av Nrt, it includes sudden onset, rapid, regular palpitations. And this particular palpitations is mainly because of the tachycardia. Right, it is mainly because of tachycardia. Now what are the other associated symptoms? So whenever there is tachycardia, what will happen to the cardiac output? The cardiac output will decrease. Now because of decrease in the cardiac output, the individual can have pre-syncopal or the syncopal attacks. Right, the pre-syncopal or the syncopal attacks. Right, why is that? Because of the fall in the blood pressure. Then the individual will also have chest pain. Now why there will be chest pain in these individuals? So chest pain, especially in the context of underlying coronary artery disease, there can be chest pain. The same patient with the Av Nrt having an underlying coronary artery disease, they can have this chest pain. And the other clinical features are dyspnea, then anxiety, right, anxiety, and rarely polyuria due to elevated atrial pressures causing release of the atrial natriuretic peptide. So these are the clinical manifestations what you will have in patients with the Av Nrt. Then you take the heart rate within the individual. So heart rate in these patients with the Av Nrt, it ranges between 140 to 280 beats per minute. Right, 140 to 280 beats per minute, and it is regular in nature. Right, it is regular in nature. What are the supraventricular tachycardias where you have irregular rhythm? That is atrial fibrillation, atrial flutter. There you have the irregular rhythm. Now, let me discuss in detail about the pathophysiology of your Av Nrt. See, in comparison to Av Rt, which involves anatomical re-entry, that is bundle of Kent in case of WPW syndrome, in Av Nrt, there is functional re-entry. See, this itself can be asked as a multiple choice question. What is the type of arrhythmia where you have anatomical re-entry? That is AVRT. And what is the name of that particular accessory pathway which is causing anatomical re-entry? That is bundle of Kent seen in patients with the WPW syndrome. Then, what are the arrhythmias where you have functional re-entry? That is AVNRT. And that functional re-entry is around the AV node. Now, let me take up this functional pathways within the AV node. So within the AV node, there are two pathways. Now what are these two pathways? Like we have, one is the slow pathway and the other one is the fast pathway. You take the slow pathway. Slow pathway, it is also called the alpha pathway. Fast pathway, it is also called the beta pathway. Slow pathway, right? A slow conducting pathway with short refractory period. So you should know this. It's a slow conducting pathway. Right? And the refractory period will be short. Right? The refractory period will be short. Whereas in fast pathway, which is a beta pathway, it is a rapidly conducting pathway. Right? It is rapidly conducting pathway with long refractory period. Right? With long refractory period. Okay. Now let me explain you the normal conduction through the AV node. Normal conduction through the AV node is as follows. That is, you have slow pathway and as well as the fast pathway. During normal sinus rhythm, the electrical impulse, it travels both through slow pathway and as well as the fast pathway as well simultaneously. But slow pathway, like I said you, the velocity of the conduction is slow, but it has a short refractory period. Fast pathway, it has faster conduction but long refractory period. So the impulse through the fast pathway, it is transmitted down, right? The impulse is transmitted down the fast pathway. It enters almost the distal end of the slow pathway, and the two impulses, they cancel each other. See, what will happen is very simple to understand. Through the fast pathway, the impulse, it reaches fastly to the distal end of your AV node or to the distal end of the slow pathway. By the time the impulse reaches to the distal end of the AV node, still the slow pathway did not enter into the distal end of your AV node. So the fast pathway, it will give impulse to your ventricle, which is a normal sinus rhythm, and it will try to enter into the slow pathway. And by the time the slow pathway is coming slowly, what the slow pathway will do? The slow pathway will come in contact with the fast pathway, and both of them, they get nullified, or both of them, they get cancelled. And that will give rise to what is called a normal sinus rhythm. That will give rise to what is called a normal sinus rhythm. Now, what is the mechanism for the re-entry? For suppose, we will consider that there is a premature atrial contraction. When there is a premature atrial contraction, which particular pathway will take up that premature atrial contraction first? That is your slow pathway. Slow pathway will take up this premature atrial contraction. The question is why? Why? Because slow pathway has short refractory period. So that is the reason why it will give the impulse to the ventricle, or it get cancelled by the impulse of your fast pathway, and then it is ready to receive another impulse. If there is premature atrial contraction, the slow pathway will take up that impulse because slow pathway has a very short refractory period. Whereas the fast pathway, I said you like there is long refractory period. So that is the reason why whenever there is a premature atrial contraction, slow pathway will take up the impulse because it has a short refractory period, but fast pathway will not take up that impulse because the fast pathway is in a state of the refractory period. Okay, so the impulse will try to travel through the slow pathway because the fast pathway is in a refractory period. So from this slow pathway, it will enter into the distal end of the AV node, and it will give the impulse to the ventricle, and at the same time it will try to enter into the fast pathway, right? It will try to enter into the fast pathway in a retrograde manner. Now this impulse will go and stimulate the fast pathway again. This premature atrial contraction, whichever has traveled through the slow pathway, will enter retrogradely into the fast pathway, and it will stimulate the fast pathway. So once the fast pathway is stimulated, and how will the fast pathway get stimulated? The fast pathway, it gets stimulated in a retrograde manner. It will not get stimulated in an antigrade manner. So once the fast pathway gets stimulated in a retrograde manner, the impulse continually cycles around the two pathways, and that will make the individual to land up in the Av Nrt. So remember, if there is premature atrial contracture, the slow pathway will take the impulse. The fast pathway is still in refractory period. The electrical impulse will be directed completely through the slow pathway. By the time premature atrial contracture reaches the end of the slow pathway, the fast pathway is no longer refractory, and the impulse is permitted to recycle retrogradely up the fast pathway. So very simple to understand. There is no complication in this, right? Whenever there is premature atrial contraction, the slow pathway is getting stimulated first. It is not the fast pathway. Normally what should happen, if it is a normal sinus rhythm, both the pathways, they get simultaneously stimulated. But in premature atrial contraction, the slow pathway is getting stimulated first. Why? Because it has a short refractory period, and the impulse will reach the distal part of your AV node, and by the time your fast pathway refractory period is over, but the slow pathway will try to revert back into the fast pathway retrogradely and will stimulate the fast pathway, and the fast pathway will continue the trigger in a retrograde manner. So this particular cycle continues, resulting in what is called Av Nrt, that is AV Nodal Reentrant Tachycardia. Okay, so this is a circus movement around the AV node. Now the point that you should remember is that, see, I have discussed the various types of AV Nrt: slow fast AV Nrt, fast slow AV Nrt, slow AV Nrt. Why? How is this names given? Let me tell you. For example, if it is the slow pathway which is activating the ventricle, and the fast pathway is activating the atria, then we call it as slow fast AV Nrt, right? Then we call it as slow fast AV Nrt. So here what is happening? The bundle of his, like the ventricle is getting activated anterogradely, but atria is getting activated retrogradely. So this is what is called as slow fast AV Nrt. And the similar mechanisms exist for the other types of AV Nrt also. Like what is that? Like for example, in case of slow fast, what did I tell you? The ventricle, it is activated via slow pathway, and atria is activated by a fast pathway. Whereas you take fast slow pathway. So if you take fast slow pathway, the ventricle is activated via fast pathway and atria is activated via the slow pathway in a retrograde manner. That is what is the meaning of the word slow fast, fast slow and slow slow. Slow slow pathway is what? Ventricle is also activated via slow pathway, atria is also activated via slow pathway. That is what is called as slow slow pathway, right? Now, accordingly, what will be the ECG findings in slow fast pathway? Let me discuss that in detail. So, in case of the slow fast pathway, there will be tachycardia of heart rate nearly around 140 to 280 beats per minute with normal and regular QRS complexes, right? And what about the P wave? The P wave, either it is hidden in the QRS complex, right? Either it is hidden within the QRS complex, or the P wave, it appears immediately after the QRS complex, right? It appears immediately after the QRS complex. So that is what is the ECG finding in AV Nrt. And what about the QRS complexes? It will be regular RR interval, but this QRS complexes will be normal or the narrow QRS complexes. And you take the RR interval will be regular, but RR interval, it becomes narrow, right? So there will be narrow RR interval, and there will be also ST depression, right? This will be the ECG changes in patients with the AV Nrt. I'll just show you the ECG also. So this is the ECG of the AV Nrt, that is AV Nodal Reentrant Tachycardia. First of all, you should appreciate the tachycardia. You take the number of boxes between the RR interval. How many number of boxes are there? It is hardly around 1.5. So if you calculate the heart rate, 300 divided by 1.5, so it will be around 200, right? It will be around 200 roughly, okay? Yes. So the heart rate in this patient is 200 beats per minute. And what is that? I have said you will have narrow QRS complexes. So you can appreciate there, the QRS complexes are narrow, that is less than, right? It is less than 70 milliseconds, right? Then followed by that the P wave. So if you take the P wave, right, you should be able to appreciate the P wave either in lead 2 or V1. We will take lead 2 itself. You take in lead 2, if you see the P wave, right, so the P wave, it is either hidden in the QRS complexes or it will appear after the QRS complexes. I can make out that the P wave, it is hidden in the QRS complex, okay? So there is no visible P wave. Why is that? Why? Because when ventricle and as well as atria simultaneously, if they are contracting, how is the ventricle contracting? Through the slow pathway. How is the atria contracting? Through that particular fast pathway. And both are simultaneously contracting. So that is the reason why the P wave, whichever is appearing because of atrial contraction, will be masked by the QRS complex of your ventricular contraction. So you will not have a visible P wave. Now, I'll just show you one ECG and please tell me the diagnosis. Yes, right? So this is the ECG. I'll just try to zoom this. Now you see the diagnosis: slow fast AV Nrt, fast slow AV Nrt, slow slow AV Nrt, fast fast AV Nrt. Now how to make out this ECG? This is the ECG of the slow fast AV Nrt. Sir, how is that you are able to tell me? Now you take the P wave. The P wave, it is appearing after the QRS complex, but it is getting merged with the QRS interval. There is no visible P wave. And I'll just show you a zoomed image of the one what I have circled. Yes, you see here. So this is your P wave, right? This is your P wave, and the P wave, it is getting merged with the R wave of the QRS complex, and that is what is called as pseudo R wave. That is called pseudo R wave. So now remember, in case of Av Nrt, that is slow fast Av Nrt, which is a typical Av Nrt, the P wave, it is merged in the QRS complex, and that particular P wave, once it is merged with the R wave of the QRS complex, it is called pseudo R wave, right? Now, to this particular same patient, if you give adenosine, right? So I have given adenosine of around 6 mg. When I have given adenosine of 6 mg, the rhythm, it will become sinus rhythm, right? So let me just show you that. Yes. So you see here, you have the same patient, I have given adenosine. You have a P wave, you have the QRS complex, and you have the T wave. Okay. So you can appreciate that even in the lead V2 also. This is your P wave, this is your QRS complex, and this is your T wave, right? This is your T wave. So the pseudo R wave have now disappeared, right? The pseudo R wave have now completely disappeared. The same patient following the resolution of Av Nrt after giving 6 milligrams of adenosine. So this is the ECG on arrival. So you can make out here that the P wave is getting merged in the QRS complex. You see, this is the P wave. Or you don't have any identifiable P wave. And once I give 6 mg or 12 milligrams of adenosine, see, actually, like, how do we treat Av Nrt? We need to give 6 mg of adenosine. If the patient is not responding, then we give 12 mg of adenosine IV. Now you can able to appreciate the P wave, you can able to appreciate the QRS complex, and you will be able to appreciate the T wave. This is the T wave. Okay, so this is the ECG features in patients with the Av Nrt, that too slow fast path. So what did I tell you? The slow fast pathway, it will account for nearly around 80 to 90% of Av Nrt. So this is associated with slow AV nodal pathway for anterograde conduction, that is your ventricular contraction, and fast AV nodal pathway for retrograde conduction, that is your atrial contraction. So the retrograde P wave is obscured in the corresponding QRS complex or occurs at the end of the QRS complex as pseudo R wave or the S wave. So that is what is called as the slow fast Av Nrt, which is the most common type. So here, what is that I have taught you? The P waves are often hidden or embedded in the QRS complex. You have pseudo R wave in V1 or V2. You have pseudo S wave seen in lead 2-3 AVF. And in most cases, this results in a typical SVT pattern with absent P wave and tachycardia. So why is that absent P wave? Because of simultaneous contraction of ventricle and atria, and the ventricular contraction impulse, the QRS complex will mask the atrial contraction impulse, that is your P wave. Okay. So this is another ECG showing you the pseudo R wave. You see, this is your R wave, pseudo R wave. This is not the normal R wave. Okay. Now, after having discussed about the slow fast Av Nrt, let me just show you one more ECG. Yes. So if you see this ECG here, what is the diagnosis? Slow fast Av Nrt, fast slow Av Nrt, slow Av Nrt, fast Av Nrt. Now let me just zoom this ECG for you. Right. Okay. So this is your lead 2, that is your rhythm strip. What is that you are able to make out? This is your QRS complex. And you can see a wave is retrograde. That means a wave is inverted after the QRS complex. That is your P wave. Then you have the T wave. So where is that you will see this? You will see this in fast slow Av Nrt. Sir, how can you tell it is a fast slow Av Nrt? See, this fast slow AV Nrt, it accounts for 10% of cases of your AV Nrt. And in fast slow AV Nrt, this is associated with fast AV nodal pathway for the anterograde conduction. So fast pathway is to the ventricle. That means you have the QRS complex. Then you take the slow pathway. Slow pathway is to the atria. That means what? It means that after the ventricular contraction, you have the atrial contraction. What does that mean? You will have the normal QRS complex and the P wave, it will be inverted P wave. Why? Because it is the atria is contracting after the ventricular contraction. That is the reason why you will have retrograde P wave. So how will you differentiate slow fast AV Nrt from fast slow AV Nrt? In slow fast AV Nrt, you don't have an identifiable P wave, or you have pseudo R wave, where the P wave is merged in the QRS complex. Whereas in fast slow AV Nrt, you have the QRS complex, then followed by that you have the P wave which is retrograde or the inverted. Okay, so if you take the ECG findings in the fast slow, first of all you should remember the fast slow AV Nrt, it constitutes 10%. Fast AV nodal pathway for anterograde, slow AV nodal pathway for retrograde conduction. Now, due to long ventriculo-atrial interval, what is this? Ventricular contraction and after that atrial contraction. So you have long ventriculo-atrial interval. Because of this long ventriculo-atrial interval, the retrograde P wave is more likely to be visible after the corresponding QRS complex. So you will have QRS P wave. Retrograde P waves are visible between the QRS and as well as the T. So that is about your fast slow path. Coming to your slow AV Nrt. This is atypical AV Nrt. In slow AV Nrt, this constitutes around 1 to 5% of AV Nrt. And this is associated with slow AV nodal pathway for anterograde conduction, slow left atrial fibers as the pathway for retrograde conduction. So you have slow AV nodal pathway for anterograde conduction, slow left atrial fibers for retrograde conduction. That means for both anterograde conduction and retrograde conduction, it is your slow pathway and it is an atypical form. Then what will be the ECG changes? Definitely they will have tachycardia because there is re-entry phenomenon. Here the P wave seen in mid diastole, in the sense you will have P wave first, after that the QRS complex. Okay, so tachycardia with P wave seen in mid diastole effectively appearing before the QRS complex. Most of the times this slow AV Nrt will be misinterpreted as the sinus tachycardia, because even in sinus tachycardia also you have the P wave followed by that the QRS complex. And the very important differential diagnosis for slow AV Nrt is your sinus tachycardia. So if you summarize the AV Nrt, if there is no visible P waves, then it is slow fast AV Nrt. P waves visible after the QRS complex, it is your fast slow AV Nrt. P waves visible before the QRS complex, that is slow AV Nrt, right? So this is about the various types of AV Nrt, which is nothing but your SVT, supraventricular tachycardia. We have another variant of SVT, that is SVT with QRS alternance. In this, the individual will have the narrow complex tachycardia, right? Retrograde P waves are visible preceding the QRS complex, right? Before the QRS complex, you have the retrograde P waves. and there is beat to beat variation in the QRS complex without evidence of the low voltage. Okay, so there is beat to beat variation in the QRS complex without evidence of low voltage, which is nothing but QRS alternance. You see this. This is what is your SVT with QRS alternance. Right, SVT with QRS alternance. It's a narrow complex tachycardia, but only thing is you have a retrograde P wave before the QRS complex. See, this is the QRS complex, right? You have the retrograde P wave before the QRS complex, and there is beat to beat variation. So this is the large complex and this is a small complex. This is a large complex, this is a small complex. This is large and this is small. This is large and this is small complex. So this is what is nothing but your QRS alternance. This is nothing but your SVT with QRS alternance. Now, having discussed, and what about the PR interval? The PR interval is nearly around 120 milliseconds. So this could be either a slow atrial tachycardia or possibly an Av Nrt with long RP interval. Right? So this is what is the SVT with QRS alternance. Now, how do you treat these particular patients with the Av Nrt? Let me just discuss treatment now. So to summarize Av Nrt, one is slow fast, where the P wave is not significantly seen or it will be merged in the QRS complex. Fast slow Av Nrt, where the P wave will appear after the QRS complex, that will be inverted. Slow Av Nrt, you will have P wave then followed by that QRS complex. Very simple. Which is most common type? Slow fast Av Nrt. Which is uncommon or atypical Av Nrt? That is your slow Av Nrt. Now, how do you treat these patients? What is the drug of choice to control the SVT? Adenosine, propranolol, verapamil, digoxin. Remember, it is your adenosine which is the drug of choice to control the SVT. You need to give 6 milligrams of adenosine, and if there is no response, then you need to give 12 mg of adenosine intravenously, right? So you have to give this in few seconds. Okay, you have to give immediately because the half-life of this adenosine is hardly around 5 to 10 minutes. So that is the reason why you have to give IV quickly. Okay, next, and contraindications of adenosine is that if the individual is having any bronchial asthma, then you cannot give adenosine. Why? Because adenosine is supposed to cause the bronchospasm, and that is the reason why in bronchial asthma patients we usually avoid this, the adenosine. But remember, what will be the first line treatment for your SVT? We have physiological intervention. What is this physiological intervention? First, ask the individual to take rest. Then you need to do the maneuvers, that is Valsalva maneuvers. What are these Valsalva maneuvers? Number one, the gag reflex. Right? Number two, application of the ice packs. Next important thing is carotid sinus massage. Right? The carotid sinus massage. So on doing the carotid sinus massage, this particular Av Nrt will get subsided. And the next important thing is avoidance of the precipitating factors like coffee should be avoided. Then tobacco, alcohol. So these all should be completely avoided, right? And the management wise, for suppose vagal maneuvers like carotid sinus massage or Valsalva maneuver, if it is failed, then adenosine should be given. And even your 6 milligrams of adenosine or 12 milligrams of adenosine is also failed, then we give beta blockers or calcium channel blockers. And remember, beta blockers are usually avoided in individuals who is having respiratory component like COPD, bronchial asthma. In those individuals, the beta blockers are avoided. In them, we give calcium channel blockers. And the calcium channel blockers, what we give is diltiazem, and then verapamil. So these drugs are avoided. The calcium channel blockers are avoided. So adenosine beta blockers or calcium channel blockers, they can suppress the Av Nrt by blocking the Av node. And the other second line therapies include amiodarone or the flecainide. Amiodarone and flecainide, they are anti-arrhythmic drugs. Your amiodarone is class 3 anti-arrhythmic drug and your flecainide is a class 1 anti-arrhythmic drug. Now for suppose if the individual is like refractory to medical management. If the individual is refractory to medical management, that is the point when we need to do cardioversion. Right? So you need to do cardioversion when the tachycardia is refractory to medical management. Okay? So that is very important. And not only that, when the individual is having or when the individual is in hemodynamic instability, like hypotension is there, development of heart failure, in these scenarios you need to do cardioversion, right? So remember now, stable Av Nrt you can give adenosine, then not responding beta blocker or calcium channel blocker, not responding to medical management, cardioversion. Apart from that, the individual is hemodynamically unstable Av Nrt, then directly you have to do cardioversion. Okay, so that is very, very important. Any arrhythmia, if the individual is hemodynamically unstable, you need to do the cardioversion. So please remember, that is a very important point. Then coming to your radiofrequency catheter ablation. Radiofrequency catheter ablation can be offered to the patients with frequent attacks for whom medical therapy is not appropriate in long term and can be curative. So radiofrequency ablation has to be done as a part of the long term treatment. So that is about the treatment of your Av Nrt, that is Av Nodal Reentrant Tachycardia. So you see the algorithm or the flow chart, right? So the individual is having SVT. Okay. Then first important, you identify the SVT, what type of SVT. If it is Av Nrt, then what is that you need to do? Vagal maneuvers, that is carotid sinus massage. And not responding, then you need to give adenosine 6 milligrams IV bolus. And not responding, then you give 12 milligrams every minute. You can give up to 3 doses. And always remember, adenosine should not be given if the individual is having WPW syndrome. Okay, why? Because WPW syndrome is a clinical scenario where there is an accessory pathway. So when you give adenosine, it will block the Av node. So all the impulses will be passing through that accessory pathway and it will precipitate the arrhythmia secondary to your WPW syndrome. Okay. Next. Now after giving adenosine, check the vital signs. Blood pressure, is there any chest pain, or is the individual is in heart failure, or if the heart rate is still more than 200 beats per minute. So for example, nothing, right? The individual is hemodynamically stable. Then as a part of the long-term control, you need to give beta blocker or the calcium channel blocker or your amiodarone or your digoxin. Digoxin usually we give if the individual is in a state of heart failure also. Now for suppose all these are present, right? Hemodynamically unstable, the individual is in a state of heart failure, then you need to do the DC cardioversion. So how many joules of the DC cardioversion you have to do? Either 100 or 200 or 360 joules of the energy should be used for the cardioversion. Okay. And if necessary, amiodarone should be given over 10 minutes. How much dose of amiodarone? That is nearly around 300 milligrams of amiodarone has to be given. So this is about the algorithm for the treatment of Av Nrt, right? So if the question is asked what is the drug of choice to control the supraventricular tachycardia, the answer will be the adenosine. But if the question is asked what is the drug which is given as a part of maintenance therapy for PSVT, right? If the question is asked drug of choice for maintenance therapy in PSVT, amiodarone, lignocaine, verapamil, adenosine. Please remember it is your verapamil. Okay, so verapamil, it is the one which is used for the long-term control of your PSVT, right? And if you take the drugs that work primarily on the accessory pathway, that is your class 1A, that is procainamide, disopyramide, radiofrequency ablation, and as well as the electronic ablation. So that is about the topic on the Av Nrt. In my subsequent session, I will discuss in detail about the Av Rt, that is Atrioventricular Re-entry Tachycardia. In this session, only I have taught you the types, the antidromic and orthodromic Av Rt. But in detail, I have shown you the ECGs of Av Nrt and treatment of Av Nrt. So in the subsequent session, I will take up the discussion of Av Rt, that is Atrioventricular Re-entry Tachycardia. Thank you very much.